Great. Well, thank you so much for being here. And I realize it's been a long day, but we're going to dive into a topic that I think is really important for all of us in cancer care. And it's a topic that has come up repeatedly throughout this conference. So just as a quick reminder, in terms of polling, we do have several polling questions. And we've got a panel today that's going to be presenting, and we're also going to have some interactivity throughout this session. So if you have not had a chance to register for this polling, just send a text to 22333, and then type in the text message ACCC. So with that, this project is a project titled Optimizing EHRs. And at the back of the room, we were supposed to have these handouts and these supplements, but unfortunately, I've been told by ACCC staff that we've run out of them because we have been distributing them throughout this conference. That supplement is available online as well, and I will be referring to it throughout this session. This project is also funded by Pfizer Oncology, so we want to thank them and recognize them for their contributions and their support in making this project possible. So what did we do? This project really looked into the growing needs for both accurate as well as integrated comprehensive data collection. We know that we need to use EHRs, but how can we use them more effectively, and how can we optimize that? And everyone around the country is doing it differently, even if they're on the same system. So we really wanted to dive in and answer some of those key questions, looking at those common challenges, the barriers to use, as well as the whole care coordination and reporting aspect of this. And so what we did was we spent some time putting together a survey, doing some focus groups, interviewing some practices, and then sort of the culmination was the output that was the supplement. But today we're also going to hear from our panelists about their experiences with their specific systems, but also within their own healthcare setting and their cancer programs. Some of the common themes that you're going to hear over and over are, this whole transitioning from whatever you might be running today to what are you going to be running if you get acquired by another health system. So are you going to switch to Epic or Cerner or to something else? As well as the whole theme of interoperability. Even within the same cancer center, you may have several different EHR systems. The outpatient medical oncologist might be on system. The radiation oncologist may be on a different system. How do we make that information talk to each other? And that's something that just came up over and over. And we got into some specific examples of things like Epic's Care Everywhere, as well as the Commonwealth Health Alliance. And then the quality reporting. So OCM came up, ASCO COPI came up, MACRA MIPS, the Quality Payment Program, or QPP, came up. And then we recently also heard that a number of community practices are now also uploading and sharing information into the ASCO CancerLink program. So some interesting sort of overlapping both projects and opportunities, all leveraging the EHR. I mentioned the supplement, and I'm sorry that we don't have any physically available, but you can find this on the ACCC website, and you'll see some of those survey highlights. As well as this whole process and the journey of transitioning from one EHR system to another, and you'll hear about some specific case examples in the supplement. And then we're going to touch upon some of these other things around the quality reporting as well as advancing patient-centered care. So with that, we want to spend just a moment asking you all, how long has your cancer program been using your main EHR system? Understanding that you may have more than one system, but if there's sort of a main system, how long have you been using it? Text your answers based on whether it's been less than 1 year, 1 to 3 years, 3 to 5 years, or over 5 years. We'll give you just a minute or so, and we'll see what kind of responses come in. Okay, so it looks like some have been less than 1 year, a fair number over 5 years, so some stability there in terms of the types of EHR systems. Still a few more answers coming in here and there. All right, so thank you for that, and our panel will sort of have an opportunity to react and respond to this once we dive into some of the specific discussion elements. So once again, I'm joined up here by Linda Frisk from Arizona Oncology, Rachel Lawlor from Cancer Care at Mosaic Life, and Judy Stone from Stamford Health, and you'll be hearing from each of them, and then we'll have an opportunity to dive into a panel. We also want this to be very interactive, and so towards the end, we will have an opportunity to get questions from you all, so just sort of keep that in mind. So with that, let me hand it over to Linda.
Good afternoon. Thank you for having me. So Arizona Oncology, let me flip here. Okay, Arizona Oncology has over 30 sites of services. We span from Flagstaff to Green Valley at the Mexican border. We encompass medical oncology, gyn-onc, rad-onc, urology, colorectal surgeons. We have approximately 90 physicians. We see about 15,000 new patients a year and about 250,000 overall patient visits annually. I have 12 in-office dispensing sites throughout Arizona Oncology. Those are 3 different models. I have one where you have one tech at one site. I have one where you have one tech, and she is like the master. She does the prior auths, she does the financial assistance and the adjudication, and then when that's all done, she can pop up the scripts, labels at different sites, and they get filled out there. Another one that's more geographically challenged just has one NCPDP site, and everything is emailed into them and they FedEx out. For EMRs, as we acquire some IMAs, they usually bring in their own EHR, so as a result, we have several. Our 2 major med-onc ones are iKnowMed and Onco, and I am going to talk a little bit about the differences between those. And then we have urology ones, a couple different ones, and Mosaic is used in our radiation sites. We use QS1 for our retail pharmacy management, and we use Centricity Business for our practice management. So today I'm going to kind of discuss the med-onc EHRs, which are Onco and iKnowMed, as well as some of our challenges in incorporating our oral chemotherapy, as well as OCM reporting, having multiple sites like this. So first, a little snafu in my spelling there, a long and windy road rather than winding road, but we have seen some cool breezes along the way, so I guess that's kind of appropriate too. But multiple EHRs do require a lot of flexibility, especially for your oral chemo with your e-prescribing and your documentation. iKnowMed integrates a software called ClearValue Plus. It helps the physicians with decision-making as far as pathways and NCCN guidelines. And how that works is when a physician enters a new regimen, the first thing that happens is ClearValue Plus pops up, and they query what you have in your progress note in the queryable fields. They also may ask you a few questions that are from the NCCN guidelines. After that, then the physicians will see the pathways come up color-coded in green for go, and then you'll see the NCCN regimens that are not on pathways, and below that you'll see the non-NCCN regimens. If a physician goes off pathways, they are required to put in an exception and explain why they're going off pathways. And then that's ClearValue Plus is a reporting tool for me, and I'll go in and I can look at the percentage of pathway compliance, and I can drill down. I can look at what physicians did what their reasons for going off pathways were, and I do report that on a monthly basis, especially for some of our value-based contracts. They want to know when we're on pathways and why we went off of pathways. And a lot of times the reasons are very good, and we will provide them those reasons on why we're off pathway. Onco EMR is not quite as in-depth on the pathways the way iKnowMed is, but man, is it cool on reporting your business. It has Onco Analytics. I don't know how many of you have that, but that is a real-time data tool where you can go in and within minutes you can know what your prescribing habits are by payer. You can look at your number of new patients. You can look at your number of patient visits. You can look at zip codes where your patients are coming from. I can go in on drugs and I can query Abraxane versus paclitaxel, for example, and I can look at how the physicians are prescribing that by payer. So for our OCM line of business, are they being cost effective? And if not, what's happening and why not? I can drill down on that. I can look at by disease state, what they have prescribed. I can go down to the patient level. I can go to the chart then and look and see why they're using the more expensive drug, and we can have that conversation if needed. On the other hand, I can also use that tool to look at margins. Since I know my margins for my payers vary, I can look and see where we are as far as our margin analysis, and are we utilizing our drugs to that benefit also. The other thing cool about Onco Analytics is I can use it for predicting budget growth for the next year, because I can see the trends in the different drugs. I can look at nivolumab or pembrolizumab, and I can look at where are we going. Have we stabilized? Are we still trending upward? Hopefully we've stabilized. I don't think we can trend upward anymore, but I can look at all of this data. And another thing I can do in Onco Analytics is when I'm looking at my value-based payers, I can look at our Neulasta utilization. So are we using that appropriately? Are we waiting in metastatic cancer until second cycle, or are we dose reducing instead of giving Neulasta? So a lot of the things that we're trying to do for our value-based plans, I can query out of Onco within minutes. Unfortunately, with iKnowMed, I don't have that ability. It's predominantly a pathway-driven program, and their reporting is not near as robust or timely in that matter. Both Onco and iKnowMed are COPE certified. Our sites are COPE certified. We do have some papers that need to be scanned in. Those are our oral and our IV consent forms, and also an oral adherence form that we do every time the patient comes in. We ask certain questions to make sure that they are still okay with their oral oncolytic. OCM, again, having multiple EHRs is a little bit of a challenge there. We have different data reportings. They're on different pathways, and they document their care plans a little bit differently and their quality measures a little bit differently. So it's a little bit more manual, a little bit more timely when you have two HRs. QS1, which is our retail computer, doesn't integrate with any of them. And it also doesn't integrate with our practice management system. So therefore, that's created some problems along the way. Financial staff who didn't understand oral chemotherapy wanted it put into our practice management system. That was a lot of duplicate work. It also did create some financial errors in that they did at sometimes document scripts that were not yet sold, or they neglected to document scripts that were reversed and pulled them out. So we got some false AR along the way, and we had to work that through too. And so our fix for that, for our QS1, is that we had to create some different reports. So we had to create a will call report. We had to make a delivery report so that we know when something is officially sold. We also have a lot of manual work that we need to do at the end of the month. If you have a script that's been adjudicated at the end of the month but not yet sold, you have to manually back that out so your expenses and your revenue match in the same month. And again, the financial team for expenses refuses to use the data. They have to use their little equation, and then we have to kind of balance that, because in a LIFO system, if the price changes during a month, that creates a variance. There's also variances, again, if they haven't reversed out scripts. And right now, we're hoping for adding an electronic AR system to help that our revenue out for our QS1 system. And in summary, I guess I just want to say, as far as electronic medical records, they all do the same thing. You can enter your patient data. The key is, in our data-driven world, that we have to make sure that our physicians are filling in the queryable fields. When I first got into Onco, comparing it to iKnowMed, I thought, man, this is a simplistic system. Then I realized, no, it was my physicians that were making it very simple. So they didn't put in line of therapy or a lot of the data that was required in iKnowMed. It's there, they just skipped it. So I think it's very important that we make sure that we run reports, we check things out, and we make sure that all of our data that we can query is in there. Onco, again, because I love their reporting, have a new tool where they can actually use some optic IT thing and they can read your progress note. So pretty soon you'll be able to query KRAS, say, and all of your progress notes that have KRAS in them will come up and you can select them. So they're doing some really cool business reporting, whereas iKnowMed is more pathway driven and we do a lot more pathway reporting. And that's about it for me.
Thank you very much, Linda and Rachel.
Hello, my name is Rachel Lawlor. I'm the Director of Cancer Care at Mosaic Life Care in St. Joseph, Missouri, which is a small city located just north of Kansas City. We have one hospital outpatient clinic, our main hub, that has lab, infusion, and radiation therapy on site. We have a few additional outreach locations in northwest Missouri and eastern Kansas. We have a full complement of on-site support services that include social work, financial counseling, dietitian, navigation, palliative care, and more recently, some APRN-led symptom management clinics. Our hospital also has a dedicated inpatient unit with oncology hospitalists, and our program accreditations are through COPE, COC, and NAPBC. So while this is a smaller program than what we just heard about from Linda, I would argue that it's no less complex. Our current EHR journey is we use Flatiron's OncoEMR in medical oncology, Varian's ARIA in radiation oncology, and the rest of the hospital is on Cerner PowerChart. So most of our referring providers are also in Cerner, or we have a few specialties that are still within private practice where maybe we have a few other little systems sprinkled around. Some of our ongoing struggles are really just what we've discussed around the complexity of using 3 EHRs. Where's the information and who has it and how can we get it in all 3 of those? There's too many portals for our staff and our patients. For example, a patient who's newly diagnosed and requires surgery, medical oncology, and radiation oncology would be introduced to 3 new patient portals within a period of, a week or 2, depending on when those consults occur. Our staff also require access to multiple systems, so most of our oncology staff are utilizing all 3 of those EHRs on a given day, as well as some other portals. So we outsource genetic counseling services through InformedDNA. Our staff are frequently in that portal to see where are my referrals, are my results back yet, things like that. Additionally, specialty pharmacy, it seems that most pharmaceutical companies have their own portal. So just our staff have a little bit of password overload there of trying to manage all of this information and bring it back to home base and get that plan of care together for our patients. Some recent projects we've worked on around documentation standardization. So as practices just grow and expand, we added a couple of new medical oncologists recently. Some of the documentation templates were just evolving on their own, and so we brought the team back together and really standardized what we were doing in order to make our coding process quite a bit easier. And our intake and departure processes for all of the meaningful use requirements we have to meet. Our scheduling was in need of a tune-up as well, so we recently did some work on acuity-based infusion scheduling, which is an ongoing project for most of us, I think. We didn't find that OncoEMR had the complexity to reflect what we needed in a given day. Cerner PowerChart actually did, and so we are using Cerner to schedule our patients on simply a block type of schedule, and then having that feed into Onco EMR. We found that we weren't able to do it in the reverse in order to, which is the way we do our billing, so we kind of flipped the pathway on that, and we've been using Cerner for scheduling in order to get our infusion optimized. Same kind of thing with our lab draw. We were able to use some new types of appointments and things to ensure our top of practice license and top of license practice, for our RNs and our techs. And then our symptom management clinic implementation more recently with keeping our patients out of the ED and the inpatient unit wherever possible. Our ED utilization is about on par with those across the nation, but I would say our inpatient utilization may be a little bit higher. So we have been working on how we might keep those patients out of the hospital whenever possible. And then we recently implemented a financial counseling workflow to make sure we're capturing as many patients as possible for drug assistance programs. So our story is pretty classic around the rest of Mosaic Life Care uses a different EHR from the cancer clinic. Our clinic, the practice was purchased by the hospital in 2010, and so the question remained what to do, and what do most small clinics want to do when they get acquired by a hospital. Our clinicians and myself, I think most of the staff, all love the simplicity and oncology-specific aspects of Onco EMR. Mainly managing that plan of care from one page. It eliminates a lot of clicks. Those clicks add up, and those clicks matter in the day-to-day productivity. So we all love that, but our system of record is Cerner. We bill out of Cerner, so that information has to find its way into Cerner. We also love that within Onco EMR, there's a lot of reporting functions, as Linda also mentioned. Their reports are just, there's a plethora for everything you could possibly want to know about your practice. So one of the recent projects we were looking at was how many of our head and neck cancer patients were receiving all the appropriate referrals before starting treatment. How was our pharmacy utilization doing? And just day-to-day visits with outstanding documentation or charges, kind of some more of the basic nuts and bolts of running our clinic. So then being in a different system just really presents that challenge for interoperability and revenue cycle for us. So again, when patients are admitted, hospitalists and ED physicians access our EMR for updated information. None of that oncology information or plan of care is fed into the hospital system. So that's one area where I really think that we need to go as looking at the EMR interoperability of just what's the safety mechanism there of making sure that everyone has the right information at the right time. And then we still have some aspects of our revenue cycle that have to be manually verified. So looking at certain reports out of our pharmacy inventory system and matching that up with our coding and documentation on the other side. So those are a few of the areas that we have succeeded and struggled with recently. Some of our quality aspects of our practice is that we have also data links from the COC, and so our Cancer Committee liaison physician uses quite a few of those reports, and we cross-match those on some of our psychosocial factors to looking at our outcomes in Onco EMR and ARIA to see what's impacting what. So.
Great. Well, thank you very much, Rachel. And now we will hear from Judy.
Good afternoon. My name is Judy Stone. I'm from Stamford Health. Stamford Health's Bennett Cancer Center has been in existence for just over 25 years. We just celebrated our 25th anniversary. It is an affiliated cancer center with a private practice group of physicians through a PSA agreement. In 2010, the hospital created this arrangement with the physician group, and it's been very successful, but it certainly does bring challenges. I am the administrator for both the Department of Medical Oncology, Hematology, and the physician group. So I sort of sit on the fence and hope not to fall on the wrong side any given day. One of the challenges that we face because of the relationship, the unique relationship between the hospital and the physicians, is that when they were acquired, they had just recently purchased a system which was not oncology specific. GE Centricity is a great practice management system, but it's not generally used for oncology. And so they were forced to buy a separate system to manage their infusion orders, and that's InfuSystems. Along with that product, or those products, came a consultant because the hospital was not in any way familiar with GE Centricity. And a point that has become really clear as I've listened to people talk over the past few days is it is simply critical to make your IT department fully aware of what a cancer center does, how very different we are than other divisions of the hospital or inpatient versus any other outpatient. We do approximately 1,000 analytic cases a year. We're not a large group, but because it's very old, and we are primarily the only provider in Stamford, have been for a long time. We see about 60,000 patient visits. We do about 7,000 chemotherapy and biotherapy infusions in 14 chairs. We are in the process of remodeling our entire cancer center, and at the same time, we're trying to implement a new EMR. We're in a really challenging market. We are surrounded by large academic centers, a nationally recognized institution, and I describe it as an infestation. There are affiliations with Mayo Clinic, with MD Anderson, Memorial Sloan Kettering, Yale, Columbia, just to name a few that surround us. So we're in a highly, highly competitive market. Our hospital is technically diverse, as others have said theirs are as well. The hospital is on Meditech. Meditech is not particularly friendly with other systems. The medical group is on eClinicalWorks. There is some interoperability, but very little with the hospital. GE has absolutely no interoperability with the hospital, except in the area of billing. And we had, at the time the doctors purchased that system, there was a third-party vendor that was brought in to connect the hospital's billing and the physician billing because the hospital had taken over all operations. The lack of interoperability brought to light the need to really find a way to make these systems and these different parts of the system speak to each other in some way. As we got into the selection of a new EMR, which we just started training, we determined that the biggest flaw or the biggest deficiency we had is that our IT department knew nothing at all about what we do. And so I'll kind of give you our timeline. In 2013, we submitted a budget request for a new EMR. And it was denied because the response was they were going to look for an overall system for the entire healthcare system. So in 2014, we went back and we said, we really need this. We are really operating at a deficit because of this non-specific, oncology-specific EMR. And that year it was denied because we were building a new hospital and our Connecticut governor had taxed all income, not profit, but income, at a very high rate. And we were having to put capital protect our capital. In 2015, we began to talk to Dana-Farber Cancer Institute. As I mentioned, the infestation of the large institutions in Connecticut, we decided that it was probably a good idea to affiliate with someone who had a solid name, and so we did begin to talk to them. One of the requirements by Dana-Farber was that we unify the cancer center's EMR systems. If we couldn't unify the entire hospital or health system with us, then at least the cancer center. And so we began to look, and that was the impetus for our budgetary needs to be granted this time. And so we began the selection process. We picked an EMR. As most of you know, the pharmacy needs of a hospital are generally more complex than you would find in a private practice of 7 physicians. And we found that this vendor, we really had not asked the right questions, because when we got into implementation, we actually started implementation in January of 2016. And when we got into the implementation and got to the pharmacy part, their pharmacy platform was not such that the hospital would agree to allow us to work with such a simplistic system. And so we went to them and we said, we really need to work on this. We are aware that you don't have this. Are you planning this? No. And then we went back to them with a suggestion that this third-party vendor that we'd been working with already had a pharmacy platform in place and would be happy to work with them to do the development work to give them this pharmacy platform opportunity, and they said no. And one thing I haven't mentioned, in this whole process, we went through 3 CIOs, the exiting CIO, the interim CIO, and the new CIO. About the time that this implementation started and we came up with the pharmacy program, we had a new CIO. And he came to us and said that the vendor had decided that perhaps they were not the right tool for us. And so we had to start over. Along the same period of time, in May of 2016, we were accepted into the oncology care model. With all that we had going on, we did not want to do this, but our administration made a very strong suggestion that we do this. They had been involved in some bundled programs, and they felt that it was an appropriate time for us to get involved. And actually, we had to agree that with all the rumblings of changes to meaningful use and OCM and other value-based programs, that really this was the time that we probably should go ahead and apply for OCM. So we did, and we were selected. And just after that is when the implementation was halted on this new project. So we had to go back to the drawing board. We started in July of 2016 and began to look at other systems. And as I said, we had a new CIO, so he wanted us to take another look at the new Meditech product. We went through the entire process again, and we finally selected, we decided, because we are on Varian's ARIA product in radiation oncology, and because Dana-Farber asked that we unify the cancer center, that we would go back to ARIA's medical oncology solution. So that happened about, I believe we finally decided on that in September, and we've been working ever since to try to get that set up, and we actually started the implementation process in August of this year. There was a long contracting period, and we started the implementation process in August of this year. The best thing that happened out of all this is a long sort of predicate to what really happened that turned out well. It made us just so aware that we needed IT support. We needed the support of someone who had data analytics background. We needed someone who had an in with the IT department, So we hired a quality manager. I say hired, really we poached a quality manager. She was a senior project manager for the IT department. She's a nurse. She has a certification in project management and master's in data analytics. And people say things happen for a reason. I really sometimes wonder if all this delay didn't occur by some magic, because when we brought her on, it was time to start OCM. It was time to start looking at MIPS and macro. And she has really, really been instrumental. And so one lesson we learned from this is you've got to have the right person or right people in place to do this sort of work. And I know I'm not telling you guys anything that you haven't heard before, but this was such a critical piece to us. So she started to build this value-based team. Someone else earlier in the conference had said that they also had built a value-based team. We brought in disciplines, all the disciplines, and started to work on the OCM requirements, and started at the same time starting the implementation with the new system, while at the same time having to rebuild the non-oncology specific system. So just by doing that, we have learned so much about what we want our new system to look like. Having someone with those skills has been so beneficial to us, because she's been able to direct us, especially around the data analytics and collection processes. If we had to spend money anywhere, that is the best money I think we've ever spent, is having somebody with that broad skill set. And so I guess the second thing is that and I know this is preaching to the choir again, you really need to get buy-in from your physicians. Although our physicians were invited to multiple meetings with both systems that we selected, they still felt they did not have adequate input into the system selection. And so I think that has to be, even though there may be always some hesitancy on everyone's part that they didn't have enough input, or they didn't know enough about the selection process or the selected instrument, it's really important to try to get as much input you can as from the clinical as well as the administrative sides. And again, I just can't stress enough, get clear with your IT department. If your IT department doesn't know about what you do, try to get them to plant someone in your space for a period of time. The hospital provided us with an IT project manager. He's never been in oncology, and I've been begging them for the last 2 months to allow him to come and sit in our suite and listen to what we do and see how different it is, and they've actually agreed to do that. We have some people moving out of a space, and he's going to come in and live with us for 2 weeks, and I think that's going to be incredibly valuable. And the last thing I would say is when you are selecting technology, I've heard this from everybody in every session. You need to look to the future for interoperability. There are some products that are coming out now. We're looking at one now that I actually believe may foster interoperability in a way that we haven't seen before. The other thing I would say is when you're talking to your EHR vendors, you need to try to get to a person at a level where they can actually affect change. I know we've talked to salespeople, we've talked to some of the lower level management about different needs that we have. But 2 things really can help, I believe. The first one is to get to someone senior enough to understand what your request is and make the change. And the second thing is to really know what it is you want before you go into that conversation. I think the success that we will have is because we have offered to be a partner with the vendor we selected. We've offered to be a review site for them, and we've offered to beta test many of the systems they're planning to work on. And I think building that relationship with that vendor, making it a collegial relationship instead of an adversarial one, is key to moving forward successfully. Thank you.
Thank you, Judy. So at this point, we have another polling question. Could we go back to that polling question? And the question is, what types of patient portals are you using? So just take a moment to answer this one. We've got one more after this, and then we're going to dive into our panel discussion here. So are you using a single patient portal that's a third-party application, or multiple patient portals? You've kind of heard some of this get addressed by the panelists. Okay, so most of you using a single portal, but several of you using multiple patient portals that link with different EHR systems, so thank you for that. And then the other question that we wanted to ask is, what types of reports can your main EHR system directly communicate to providers outside of your cancer program? So if you wanted to share quality information and other reports to these clinicians and communicate with them, whether it's through as opposed to sending it through fax, are you able to send this kind of information directly? Please select all that apply. So kind of an interesting mix. We still have some responses coming in, but okay. So looks like mostly labs, imaging, provider notes, medication lists. The one deficit seems to be around survivorship care plans, so perhaps that is also an opportunity for us moving forward. So at this point, I want to allow the panel to respond to some questions, and one of the first questions that we have for this group is around just their use of quality reports. So we know that in this world of whether you're participating in the OCM or Quality Payment Program and MACRA and MIPS, you can generate quality reports. Sometimes those reports may lead to action, and sometimes they may not. So I guess the question is, how are you using quality reports? Where have you found them to be really beneficial? And we want to hear from you all. At the same time, if you all have questions for the panelists, we want you to start lining up at the microphones as well. So regarding quality reports and the use of them, who would like to begin?
I'll go ahead and get started.
Just get right up to the mic, Linda.
All right. So we have a QA report, committee for OCM, and we do have our reporting in there. Again, because of the duplication of EHRs, we do report out on both of those and go through, as well as we look at the OCM data that we receive from CMS too. And that's a little bit hard to decipher, but we're also looking at another tool called InfoDive, which has some tremendously good reporting tools for OCM, so we're hoping we can get that on board too. I think that reporting and doing it quickly, efficiently, and in a way you can understand is going to be key for our future. And that is a product like InfoDive that puts it all together from multiple EHRs, I think is going to be very important for a lot of us moving forward.
All right, thank you, Linda. Rachel?
So at Mosaic, we have MIPS reports that come out of Onco EMR. We pull them on a weekly basis and see how we're doing. We had more of a deep dive a few months ago and found our areas for improvement around pain documentation, some different things like that, and just started working towards it, and now have a quality review every 2 weeks to see how we're doing. We also use RQRS for our accreditation, and we have some of our outliers there that get reviewed at Cancer Committee on a quarterly basis. Great,
thank you. Judy, did you want to add to that?
Yes, we, because we are in a non-oncology specific EMR, we had to develop our own tool, and what we did was create an intake form, and multiple people throughout the care team entered data into this intake form. It answers OCM, it answers MIPS, it answers COPE, et cetera. The intake form then populates a flow sheet, and we are able to query the flow sheet, and that's how our quality metrics appear and get measured. This was a device, I guess you'd call it, created by the quality manager that we hired, and then we take those reports, and that goes to the value-based care team, and we work, we look at our successes and our failures, and we work from there.
Great, thank you. Questions from the audience? So if you do, please just step up to the microphone and yes, go ahead.
I have a question for the panel, but also for the audience. Our hospital system utilizes Cerner, and we are on Mosaic, and also our radiation clinic is on ARIA. So we're in the current status of determining if we're going to go over to Cerner. So I can't recall which system hospital is on Cerner. Did you guys look at the oncology program for Cerner, and is anyone else in the room utilizing the oncology program for Cerner, and what's your experience with that?
I did look at a demo of it about a year ago, so I will say that in my past experience, I had used Epic for 9 years before coming to this practice and starting to use Onco EMR, so it looked much more familiar in terms of just being more clicks and more complex. And I did note that it does not come with a chemotherapy library, a regimen library already built. And so that was one of our concerns around who would manage that, creating those. Onco EMR does populate now all the NCCN guideline regimens, which is wonderful. So that was one piece of feedback that we gave to Cerner, is that we would like to see the same out of their product. I don't know if anyone else is actually on it.
Yeah, I think the ACCC listserv is actually a great resource where you can ask those questions and meet with other users who might be using that type of module or add-on. But let's move on to the next question. So if you could go ahead and step up to the mic.
Hi, thanks so much for your time. So I work at Mount Sinai. We're also participating in the oncology care model. We also do a lot of the other things that you guys work on with COC and ASCO COPE. I'm just curious to get some of your perspective. So now that we are measuring and trying to demonstrate a lot of the high quality work that's happening at our respective organizations, how have you kind of used this data that's a little bit more accessible at your fingertips to really review quality as a cancer program, both integrated within a hospital or within like a larger health system? So both operationally research and quality reporting of what we should be doing for all of our cancer patients.
Okay, so I started with Neulasta in metastatic colorectal cancer, and I presented NCCN guidelines to my physicians throughout Arizona and got them, and also through our P&T committee, and got them to agree that it wasn't advantageous to use Neulasta in FOLFOX, FOLFIRI, metastatic colorectal cancer for your cycle 1. So we now, I can query that with reports now, and we're trying to reduce that and instead use a dose reduction or just a wait and see unless the risk factors are indicating that you do need to use dose reduction. And so every time a physician now orders Neulasta cycle 1, day 1 for FOLFOX or FOLFIRI, they are asked to consider dose reduction or a wait and see approach on that as we try and reduce some of our costs for supportive care drugs.
Thank you for that example, Linda. Does anyone else have any other examples they'd like to share?
I I had a similar example with Amend versus Zofran and another with Lupron versus Eligard. So a lot of drugs, just a regular drug review, we have a supply chain pharmacist who's able to help us and do a deeper dive into most of that data and look at our cost versus outcomes and why we're making the decisions we are.
Great, thank you. Any other questions? Yes.
I was wondering if you all could, most of the stuff you're doing right now is directed either at the provider or insurer. What do you see in the future is how you could share this data with patients? What would it look like? You know, it's obviously the same, what you're giving insurers and each other is not going to be the same thing you give patients, but I'd be curious with your experience, what do you think a patient would want to see? And how far are we away from actually really being able to get some quality data back to a patient?
I think patients want to see value. So they want to understand if they're, an example that I have, I might as well say it, would be sandostatin and somatoline. One is quite a bit more expensive than the other one. And if we're going to switch from one to the other, we need to have a good explanation for that patient why. You need to be able to show them that either you're giving them cost savings by going in one direction or you're giving them improved efficacy in another direction. So patients want to see value for their money. They don't maybe dose reduction in a metastatic case as opposed to Neulasta. So I think those types of decisions eventually we will be sharing with patients and showing them how we can reduce their cost and provide them value.
I would agree with what Linda said, but also simply specific data to what this is my kind of cancer with my comorbidities and risk factors. What are my odds of survival? I mean, really, that's the question we get most is, if I'm going to survive, wonderful. Am I going to be disfigured? Am I going to have all my function left? Which treatment is going to provide me that? Some people will pay $5,000 out of pocket to have a treatment that doesn't cause hair loss. So it's all a matter of what that particular patient wants. But I think it will be a process that is iterative and collaborative, hopefully with patients, administration, and physicians to decide what is appropriate to share and what will be valuable for patients to understand.
Great, thank you. One more question?
Thank you. Really a lot of good information. So I wonder, do any of the EMRs that you use currently allow for a double scanning in the MAR for two nurses to co-sign the chemo with their badge?
Epic does.
Epic does?
Mm-hmm.
Okay. And then,
or maybe not with the badge, but they can do
yeah, currently we use McKesson Paragon, and we do a double scan, except for the initial dose. So you've got to sign in electronically with the keyboard, but after that you can scan. Oh. But we're looking at the Varian product. And other question, was the distress screening built into any of your programs?
Yes.
Okay.
Yes,
right,
as a matter of fact, our distress screening program, when distress screening became an issue, received an award from ACCC. It is one of the key things that we are focused on for improvement. We are extending our program to include a formal protocol for follow-up on patients at the various levels of reporting from the tools, and already have had some good success. We've uncovered a lot more using the PHQ-2 and 9 than we had with the pure distress screening in the past.
Thank you.
So unfortunately, we're out of time, but I want to remind you that we have this wonderful supplement that's available on the ACCC website. And that will actually highlight some of the survey information, the focus groups, the interviews that we did, the site interviews. And just regarding some of the other issues that came up during discussion, so survivorship care plans, for instance, is one of those areas where many EHRs we found don't have that built in. and therefore a lot of groups are using these add-ons and other software like that. So the supplement will sort of address those issues, those kinds of questions, but we also have the opportunity after the panel you can come up and speak to the panelists. So at this point I want to just thank the panelists for contributing to this discussion, and thank you all for your time today.